Tonight, we're very fortunate to have Patricia Brown, who is a graduate of University of Richmond, and according to her biography, has got a Phi Beta Kappa back in the day, and now she's a lawyer, and she is in charge of the Johns Hopkins Healthcare, which involves a Medicaid program, among many other things. There's more than I can possibly read on her biography here. I wanted to just say a couple words. We're going to have a Q&A session afterwards, and I have a microphone that, since we're recording everything here, that I want you guys to make your questions and answers into the microphone. And I'll be walking around with it when the time comes. So here's Patricia Brown.
Hey guys. How are you? I'm not bad. I've been running around. They haven't had me. I did go to the ladies' room before this because they haven't given me one break. I had my last caffeinated coffee at noon today, which is very unusual. So if I start talking slowly and I don't look like, hey Ryan. Normally by this time it's just the middle of the day for me, right? And as I was driving here, I arrived here at 3 o'clock and made some comment about that, and they said, oh, that's true for the kids too. They don't start their day till 3 o'clock. So hopefully you guys are in the middle of your day too and are actually still interested in learning. So hopefully I can teach you a few things. But I'm not going to talk about, I'm going to talk about healthcare reform, but I'm actually not going to talk about in detail what's happening in Washington. But I do need you all to note this date, this week, because it is one of rather significance in our history, in my world. We've been talking about healthcare reform at Hopkins for years. We've been talking about the need to have it for years. The last 7 or 8 months, we've been talking about what's happening in Washington and actually suggesting it's really not reform, at least the healthcare reform that we've been thinking we need in this country. It's a piece of it, and one can argue whether or not it's the right piece to go first, and I can talk a little bit about that. But let me share with you a little bit about who I am, and then I'm going to get into the presentation, and I'll share with you a little bit about why this presentation. So as Cynthia said, I am a graduate of the University of Richmond, 1982. This building wasn't here then. We were not allowed to visit male dorms then. That was when they were separate. We all ate in separate dining halls. We were allowed to go to the men's dining room. But why would you? Because you lived on the West Hampton side of the campus, and you had a lovely dining hall right downstairs from your dormitory. So it's a little bit of a different place than I remember. Still beautiful, but I've already been impressed by the interest of the students that I've met so far in their learning, and so I'm glad to know that you all are taking advantage of what's been given to you, because it's quite a lot. So it's a privilege for me to be here. I am a lawyer, but about 12 years ago I was asked to diversify my job responsibilities at Hopkins, and was given the opportunity to begin being on the business side of healthcare. And I agreed to do that job for 3 years, and that was 12 years ago. Just a year ago, I recognized that there were physicians at Hopkins that didn't even know I was a lawyer. And so then I had to forget the fact that I identify myself as an attorney and actually now declare myself a healthcare executive. But I will tell you that my law degree drives my business success. It is because of the way I was trained as a lawyer that I think I've been successful on the business side. And I'll also tell you that what I've learned is that no matter what my training, if I want to learn something different, then I can learn something different. And that's what I've taught myself in the last 12 years. So now I still retain legal responsibility at Hopkins in my area of expertise that I have had for 25 years. But then I also run a major division of Johns Hopkins Medicine, and I'm also responsible for, on the delivery side, for managed care, insurance, payment policies, procedures, contract negotiations, as well as clinical delivery models, innovation, and really trying to move Hopkins from an acute care general hospital that has other things to a healthcare system an integrated delivery system. So we'll talk a little bit more about that. So why this talk? I was asked 6 months ago to co-chair a formal effort at Hopkins to prepare us for healthcare reform. And that was an important thing to happen because someone, i.e. my bosses, recognized that we needed to prepare for it, that it was going to change things. And then two, that we needed to prepare for it before the healthcare reform legislation was passed, because the fear was and is that the result of any legislation is going to be more pressure on the delivery side. And so I was thrilled that I was asked to chair that effort. But I made the suggestion immediately that I be provided a co-chair who was a physician. Because a lawyer / healthcare administrator, certainly not a managed care executive, should not be the one telling physicians how to change. Docs need to do that. And so they agreed right away. And so I have as my co-chair the ex-chair of cardiac surgery at Hopkins. And I point out that he's a cardiac surgeon because any of you that know surgeons, they really don't know anything about healthcare, right? They know about how to do their surgery. So they don't necessarily worry about much after the surgery's over. And so my co-chair, chair of cardiac surgery, has had to move from that world of, okay, just procedure, to broad thinking about how we should transition the Johns Hopkins healthcare system from its current state into a new state, not just driven by healthcare reform, but driven by our own acknowledgement that we can do better by our patients. So we're co-chairing this effort, and we've begun the work of really highlighting to all of our constituents that things are going to have to change, and we want to control that change. We don't want it done to us. We want to do it and make sure that we control the agenda. So a couple months later, this doc says to me, I'd like you to come and do a speech to my colleagues around what you see going on with healthcare reform. So I said, okay, tell me about them. And he goes, well, they're all about my age or older. And Bill, my colleague, is 62. I said, oh, okay. And what's the forum? Well, we get together twice a year. We're called the Baltimore Monthly something, although they've stopped meeting monthly. And we're basically just a bunch of old colleagues who like to reminisce about how great work we do. And we just get together. We take ourselves out to dinner. And there's no women except one who's been invited. The group has met for 130 years, the oldest group ever. And we go to very fancy places and we dress up. I said, well, do you bring your spouses? No. Oh, okay. So it's a bunch of old men. How dressed up do you get? We all wear tuxedos. Oh. And where are we going? The Center Club, which is this very fancy, kind of stuffy place. I said, so there's a bunch of old men who get in their tuxedos and go and drink cocktails and pat each other on the back about how great they are twice a year. And I consider myself young, you want this young professional lawyer, who they don't really like lawyers, to come and tell them what they need to be thinking about with regard to changing their profession? Okay, make sure I have a glass of wine or two before I have that discussion, but I'm happy to go. And so this is the first time I gave this speech, and I will tell you, I will tell you afterwards that your reaction to this will be different from theirs. But what's interesting is that what I was telling them is that what they learned as docs needs to change. We need to teach our physicians to practice differently than the way these guys were taught, and they recognize that. So this speech it's going to have a Hopkins feel to it, because I was trying to suggest where Hopkins needed to go to prepare for healthcare reform, but I think it will have some general principles that are clearly applicable to the whole healthcare system in this country. So with that, let's talk about the current situation. Before I do this, how many of you would suggest you are generally knowledgeable about healthcare and healthcare reform? Generally knowledgeable. No one's raising their hand high, but some are raising their hands halfway. How many feel as if I know it's been front news, but I just really haven't read any of it? Most of you. But obviously, all of you care about it, right? Because I don't know that you would necessarily be here, except for your class. So let's talk about the current situation. And I'm going to go through this quickly, but I assume that you at least know this, that the spending in the United States is projected to double by 2020. Huge healthcare costs skyrocketing. 21% of GDP will be healthcare expenditures. You all know what GDP is, I assume? That's twice the average of European countries. So it's a lot of money. Some could ask the question, why is that bad? Maybe we want a society that dedicates 21% of its GDP to healthcare. But there's an assumption that it's probably not affordable, right? So high skyrocketing costs. We do know that the U.S. ranks well below other countries with regard to healthcare quality, which is appropriately embarrassing to us, right? I mean, if you're spending more money, you'd think that you would be getting better results. Well, the facts are that we're not, at least as compared to other countries. And it's not just with regard to public health indices, but also outcomes, general outcomes. We waste resources, and we know this because everyone who's in the system acknowledges it. And we deliver wide variations, so there's no standard that we can suggest our country is attaining with regard to healthcare quality. Wide variations geographically and otherwise. And everybody agrees that the payment model is flawed. And what that means is today, compensation, how physicians are paid, how hospitals are paid, is basically based on the services they provide. It's like you go into a supermarket and you buy an apple, you pay for it. You buy your Tide, you pay for it. Similar healthcare system. You go to your doc, you pay for a visit. You need operation, you pay for the surgery. You just pay as you go, or your insurance company, if you're lucky enough to have insurance, they pay as they pay as you go. So there's no connection to the payment to the product, i.e. pay for quality. So everybody acknowledges that payment model is flawed. But what's not that enlightening is that this is new news. This has been understood. Those things that I just talked to you about, this has been understood for years. Years. These are just pictures of books that have been published on this type of issue for years, beginning with the far right, 1933. Johns Hopkins professors themselves wrote a book in 1933 around the cost of medical care. A committee was formed to study the then increasing cost of medical care. And they suggested then that the model that we had in place, incented by our payment formulas, was not ideal, and that medical services needed to be provided differently. And so this is almost the sad story about this, that we're sitting here this week wondering if healthcare reform is actually going to pass, thinking that if it doesn't, the conversation is not going to come up again, at least until the next presidency. Yet we, the folks in the know, have understood that there's a problem for years and years. And we're teaching our students that there is a problem. So not new news. So what is the challenge? How can we reduce costs and improve quality? That's it. How can we reduce costs and improve quality? And each of you have your own perspective as to what's broken with the healthcare system. But I think all of you would share a view that it's broken. And what do you base that on? You probably can't call your doctor when you're sick and get it in that day. You probably can't even get in that week. And so that you may not feel good about. A lot of you may feel as if, or at least your parents who are paying the bills, may feel as if they can't trust their insurance company to actually pay the bill. Because they're not sure what's covered or not covered, and they're not sure what their copay is or what their responsibility is. And even worse, if they pay the bill, it's probable that they're probably paid wrong. And then you've got these explanation of benefit forms that you don't understand. And then you have to call the insurance company. Oh, and then guess what? You have to wait on the phone for 30 minutes before the person actually gets on the line. Oh, and then, okay, now you have to go and make another appointment for, you've just been diagnosed with cancer, and they say, go see the specialist, and you call the specialist hoping to get in tomorrow, and you can't get in for 3 months. Oh, well, wait a minute, I'm dying here. What do you mean I have to wait 3 months? So you all have your own stories, I think, about the healthcare system, but I think everybody would acknowledge that it's broken. True? Everybody basically feels that way? Nobody's happy about healthcare. Okay, so what's Washington doing? In June, I believe it was the end of June, Obama made his first major speech around healthcare. Prior to that speech, the media was talking about healthcare reform. Healthcare reform was the term. In that speech, Obama changed the words, and I will never forget it, because I knew that the healthcare reform was the wrong title, if you will, for the discussion that was going on. And what he said was, he used the term health insurance reform. That is what is going on in Washington now. This is not healthcare reform in the broad sense. This is really healthcare insurance reform. And what that means is that if you think about the system and why it's broken, and the various places, if you will, that it's broken, there's the insurance side, which is the coverage side. 40 million Americans, or people that live here at least, and I'll explain that in a moment, don't have insurance coverage. And most people would at least acknowledge that that's probably not ideal. So it's broken on the insurance side. And then I just a few minutes ago talked about it being broken on the delivery side, right? Your experience when you access healthcare. This reform discussion in Washington is really about insurance reform. It's about the first issue. And people in the know and with experience are questioning the appropriateness of starting first with insurance rather than starting with the delivery system. And we can talk a little bit more about that. But this is insurance reform, and Obama made that clear when he made his first major speech. This is about coverage. This is about those 40 million people getting insurance coverage. Now, the fact of the matter is that at the same time, Obama stopped saying 40 million people. He changed it to 30 million people. Who are those other 10 million people? Illegal aliens. People that are not American citizens. And politically, the White House made the decision that that was just a battle they were not going to fight. So basically, generally speaking, and I'm being very general here, but generally speaking, it's that 10 million people are people that just don't have American citizenship. 30 million people are what the current healthcare reform legislation is hoping to address. So what is the current legislation generally talking about? Health insurance exchange, which I'll talk a little bit more about. Public health insurance option, guaranteed coverage, mandated minimum benefits, and then mandated employer benefits. These are the general categories that are in the bills. Health insurance exchange. What that is the concept of creating more market, more opportunity to purchase different types of health care insurance plans in a particular area. You all are probably from a variety of states. It's likely that the state that you live in has a major carrier, i.e. a major insurer, and it's likely that that major insurer is a national health plan, such as Blue Cross Blue Shield, Aetna, Cigna. You all know you have insurance cards in your pockets. Most of them are from your parents. These generally, this resonates with you, Blue Cross Blue Shield and Cigna and Aetna. So those are the national health plans. And although there's many, many others, and I run several of them, so there's many other options, and it basically depends on your parents' access to insurance, which is probably through their employer. But this health insurance exchange is to shake that up a little bit. It's to provide more choice in the market. so that the Blue Cross Blue Shield, the Shields of the world don't control the marketplace. I was talking to Dr. Castle earlier, and he said that Anthem, I think, is the major insurer here, and it is like 50% of the market, which means that there's not a lot of choice, right? Because there's one major insurer. In Baltimore, it's the same. Blue Cross Blue Shield. Anthem is the Blue Cross Blue Shield. That's the name for their Blue Cross plan. So anyway, so Obama says, no, that's not good, right? Because have you all taken economy, right? Supply and demand choice, more choice, the better product. And so that's the concept. Let's introduce through this exchange more products. And as part of that, introduce a public insurance option. And why? Because there's this underlying premise that the public insurance product can incent private enterprise to be more efficient because the public product is going to be cheaper. How the public product is going to be cheaper, no one really understood or understands, but it's likely that it will be because of the way they'll pay, because generally the government pays physicians less. So the concept is introduced into this mix another government program that's going to compete then with the private enterprise, and through that competition you'll get less cost and they hope a better product. So that's in the legislation. Guaranteed coverage, everybody will get coverage except for those poor 10 million people. That they're guaranteed. If you go and buy insurance, you will be given insurance. And insurers have to agree to allow one in. Mandated minimum benefits, which means that whatever it is that this new marketplace is going to offer, that there's going to be minimum benefits that are going to be sufficient to be generally keep you well. Enough benefit to be able to maintain not optimal, but some level of health. So preventive care, normal usual surgeries, probably not my favorite topic, gastric bypass, right? Gastric bypass is probably not going to be a minimum benefit. But normal kind of services would be provided. And that, in addition, there's a concepts in some of these bills around mandating employers to provide either a health care plan or pay into a pool, get penalized and pay into a pool if they don't. So that's generally what this insurance reform is looking like. It's basically introducing more competition into the market, hoping for then better products that are more efficient, more quality, less cost, driving healthcare costs down while you insure more people. Get it? Okay. So what's the political take on this? So the Democrats love this, right? This is kind of a Democratic initiative, not necessarily meant to be, but it's certainly come down that way. I don't believe that there's one Republican at this point in time that is a certain yes vote on healthcare reform. And the Democrats believe that this will ensure that all will have affordable coverage in a competitive market. There's an assumption that competitive markets will, by definition, result in less cost and therefore more affordability. So they're very certain of this. And then to fight off the naysayers, they're saying, but if you have health care now that you're happy with, you can still keep it, right? You've heard them say that. If you have what you have, if you're happy now, you can still have that. And seniors that are a major voting bloc in this country, seniors, don't worry. You can still count on Medicare. Medicare is not going away. Medicare is staying as is. So seniors, no need to be worried about health care reform. There's healthcare legislation that would expand the workforce, and there are provisions in these bills to expand training slots, to allow academic medical centers such as Johns Hopkins to train more people, to deal with the fact that now you're going to insure more people, and so you need a bigger healthcare system to meet those needs. There's provisions in there that would, they hope, would modernize and improve the Medicare system with regard to administrative simplification, eliminate fraud and abuse, which is part of our current healthcare system, and basically get waste out of the system. And then the Democrats have said that, as has the CBO, the Congressional Budget Office, that this will not add to the deficit over a 10-year period. And Obama himself has said, I'm not signing a bill that will add to the deficit. all of that is projections, right? They're projecting what the costs are going to be, but they have evidence to suggest that this is a reasonable assertion. So that Dems are kind of happy here. This is what they think we need to do. The Republicans, not surprising, intrusive. We don't like big government, Republicans say, right? We are small government. This new legislation, by definition, adds bureaucracy, and it adds a hell of a lot of bureaucracy. So Republicans are not happy about that. Intrusive bureaucracy, by the way. You heard during a little of the nastiness that went on in the summer, the death panels that the Republicans, or at least some folks that were being suggested that they were affiliated with the Republicans, were suggesting that this healthcare reform is going to introduce death panels, and insurers are going to be able to dictate whether or not somebody gets services. So that fear factor was certainly part of it. The Republicans also take the position that cutting payment rates for public programs, because this bill also includes some reduced payments and trying to get savings out of the system by reducing how much we pay physicians, that's not going to take costs out of the system. That's just going to result in shifting costs. Who would you shift those costs to? Patients and doctors. So the theory is that the government is going to save money by paying physicians less, and the physicians are not going to be able to deal with that, so they're going to charge their patients more, and it's cost shift. Excuse me. They're also suggesting that insurance premiums, by virtue of that whole dilemma, are going to go up. So because they don't believe that this is going to reduce costs at all, they think that costs are going to go up, and therefore insurance premiums are going to go up, and therefore employers are going to have to pay more, individuals are going to have to pay more, families will have to pay more, and all of that is going to result in access going down, because physicians are not going to want to provide services in this now very costly environment. These mandates, all of what is going to be provided for in this new federal legislation, is going to require some increase in costs, at least initially. They're proposing new taxes to cover those costs. And so the Republicans are saying these are just new taxes, and we don't want to increase taxes. We want to actually reduce taxes, so they're not happy about that. And then the real big one is this last one, is that as this legislation moves more and more people into federal programs, either through increasing the current government programs, Medicaid specifically, or through the provision of subsidies, government subsidies. All of this in Republicans, again, general category here, view is one step closer to single payer. And that is the big fear. And I can tell you in my experience that no one really wants that. I mean, there's a faction of the American public that would support a single payer system, but no true political powerful faction. And so that's the Republicans are basically saying you're just moving in that direction, and this is a bad thing. So, what is in my view, the impact of this legislation, at least in the short term? There's no doubt that more people will have access to health care, insured health care, because that's what the plan is going to do. It's going to require people to buy insurance or allow people to be given government subsidies to purchase insurance. It's also going to allow small employers to buy more affordable insurance, so therefore improving access there. And that is going to result in more people accessing the healthcare system. That, frankly, and I have my own experience in this in the state of Maryland, that is going to create a bubble, a huge increase in healthcare costs in the short term. There's no way around it. If you're going to insure more people, those people are not accessing healthcare now, at least not in a continual way. Most of them are accessing healthcare through the emergency room when they're in an emergency situation. Once insurance reform takes place and those people are given the opportunity to present in a more normal way for healthcare services, that they're going to do so. And we know this because we have our own experience in this regard. Happened in Massachusetts when Massachusetts reformed its system a couple of years ago. That's going to require more physicians to provide more services, and it's going to provide some more costs because people are going to have to be paying those docs for those services they're providing. So it's going to require in the short term, it's going to result in the short term in a huge cost bubble. There's no doubt that increased competition could result in more efficiencies, but there's really no reason, there's no evidence to suggest, because there's never been a real health plan that's been able to prove this, that increased competition and increased efficiencies will then be passed on to the consumer. Now, why is that? Most health plans, national health plans, with the exception of Blue Cross Blue Shield plans, but the Aetnas and the Cignas of the world, they're for-profit companies. So they are incented to make money for themselves and for their stockholders, shareholders. So the dynamic in the for-profit world is the more money you make, the more money you make, right? It's not an obvious thing to give your profits away. But that's what this legislation is proposing, is that they're going to create efficiencies and then hold these insurers accountable for retaining only a portion of their profits and making sure that all of the rest is provided, is paid for pursuant to medical expenses. So there's really no clear path for this savings to come back to the consumer and result in less costs being paid by us, the patient. But again, over the course of time, that would be the theory. So this last point around cost shifting is what I'm talking about. This cost shifting is likely to continue, and then consumers, us, will have to bear more responsibility with regard to our decisions as to what healthcare we'll access, because it's now out of our pocket. So years ago, you had your insurance card, and it didn't cost you anything. It may have cost you $10 to go to a physician office. The future is going to be very different. It's going to probably cost you more than that. It might cost you $30. And then if you go to the emergency room, it's going to cost you $100 because they don't really want you in the emergency room. They want you to think twice before you go. And that's the current world. But the expectation is that as people are trying to figure out how to reduce costs, they're going to do some more cost shifting. So in order to become more competitive, at least in today's world, it is likely that insurers, the payers, including the government, will really do the only thing they know how to do. And that is reduce payment to docs and to hospitals. That's the surest way to reduce cost to them. And indeed, that's what the federal government has done. So the federal government, you all have heard about the crisis of the Medicare program, and the fact that the Medicare trust fund is going to go belly up in 2015 or whatever the most recent, 21 or something. And what are we going to do? Well, what they have been doing to try to manage that is they've basically put a freeze on payments to providers. So docs today are getting paid by Medicare, the federal government, which is about 30% of the healthcare system, basically at the same level that they were paid in 2001. Now, there's been some inflation since 2001. So they've basically had significant cuts, if you're getting where I'm going. So that's what Medicare did, because they had no other ideas to reduce costs. So they just stopped paying docs. And so that has its own dynamic. So it's this general fear from the healthcare delivery system side that this might be the short-term result. But the trade-off is that more people will get health care, and then perhaps more people will be healthier, and that over a 10-year period, when it's all kind of works itself out, that we'll come out of it okay. So this shows you just in diagram where the healthcare spend is, the total dollar. So here you see $1. Just so you know, it takes about 15% of that dollar, and that's a high number. Medicare is much more efficient, by the way, with regard to administration, but there's reasons for that. But about 15 cents of every dollar goes into administration. So the paying of the claim, the sending you the card, the answering the telephone, the setting the benefits, all of the stuff that you expect your insurance company to do, that's about 15 cents. About 80 to 85% then of your dollar goes to medical costs. And that's generally evenly distributed between hospitals and docs. And I say docs, nurse practitioners, other non-hospital providers. And so that's the current state of affairs. And that's probably not going to change too significantly in the short term. I think that it's hopeful that 15 cents on administration, when you introduce competition, you do all that I described, that would be reduced to 10. But under the current legislation, the insurer can keep the difference. The current legislation basically wants to ensure that there's no more than 15% that's kept on the payer side, if you will. And then the hope is over the course of time that there will be less money spent on hospital care and more money spent on non-hospital care. And then hopefully that dynamic will then create a smaller dollar because people are getting services in the community. They're getting them early before they get sick and therefore not going to the hospital as often. And that new dynamic will reduce the pot. You following me on that? So that's the hope. But we know that every system is designed perfectly for the results that it gets, right? You all have heard that term. So why is this dollar the way it is, and why is it that healthcare reform could change what it might be in the future? I talked to you about the fact that healthcare reform today is really about health insurance reform. But those of us in the business know that that's not going to get us where we need to be in the long run, or frankly, even in the short run. We need to reform the delivery side. Hello. I hope I didn't do that. Oh, our guy in the back did that. Thank you. We need to reform the delivery side. And what do I mean by that? So I talked to you about the fee-for-service model. That's what we call it. You go in, you get a service, you pay for it. Your insurance company pays for it. That model promotes a fragmented approach to healthcare. It is episodic rather than integrated. So what I mean by episodic is that you only go to the doctor when you're sick. And when you go to the doctor, he may not know that you were in the emergency room the week before. Or he may not know that a year before you were diagnosed with prediabetes. Because all he's dealing with is what you're presenting with, or she is dealing with, is what you're presented with today. That's fragmented, particularly when we know in this country, most healthcare costs are associated with people with chronic conditions. People that are very sick or possibly could be very sick by virtue of a chronic condition that they have. Diabetes. 15% of our employees at Hopkins have diabetes. 15%. That 15%, that patient population is driving about 60% of our costs. Because these people are actively engaged in an illness that requires healthcare services. So that dynamic is true all throughout our country. And you all probably read about chronic conditions, chronic pulmonary disease, heart failure. And you've also probably read that many of these chronic conditions are driven by lifestyle. Smoking and obesity. Those are the two major public health dilemmas in this country. And it's those two public health issues that are driving the healthcare cost trends that we're talking about today. That's an interesting statement about our country. It's not true in every country. Yet in every country, they're suffering from this healthcare cost increase problem. And so as I think more globally, because Hopkins is a global player, when I think more globally about this healthcare problem, you need to understand what your particular facts are with regard to your population. In this country, it is chronic disease, no doubt about it. So the current model fragments the approach to care, and it emphasizes volume more than value. And what I mean by that is if you're paid on a fee-for-service basis, the more services you provide, the more fees you get, the more money you get, and you're incented to keep doing it. You all have heard the term churning. So if a primary care doc needs to make a few more bucks, his only option or her only option is to see more patients. And, I don't really want to work more than 10 hours today, but I still want to make more money. So instead of spending 15 minutes a day, 15 minutes per patient, I'm going to cut it back to 10 minutes. So I can see more patients, get paid more, right? Fee for service, and then still make a living. That's what the current system incents. We had this case in Baltimore, which is really amazing, and it was not a hospital that Hopkins is affiliated with, but it is a major hospital. And as we speak, there is Doc, who has been just last week charged with putting stents. You all familiar with the term stents? Somebody has a heart attack, they have a blockage in their valve, and in order to prevent a heart attack, you put a stent in that to break up the blockage. This doc is accused of putting stents in patients that didn't need them. And why would he do that? Because every time he put a stent in, he was paid thousands of dollars. So these patients came and said, I'm not feeling well, and it is alleged that he said, you got a blockage, let's go operate on you. Obviously not an ethical thing to do. Obviously presents huge patient safety issues and quality issues. But why would one do that? Unless you're obviously he is a little crazy, but he's doing that for the money. Because the system incents that kind of behavior. Now that's obviously an overstatement, but the churning, this concept of volume, is what's broken. And then this concept of downstream. Integrated delivery systems have been in play for 15 years, started in the 90s. What that term means is physicians affiliating with hospitals, and hospitals buying physician groups or getting in the home care business, or in Hopkins' situation, buying a managed care company and integrating all of these different component parts of the healthcare system. And then the theory is that if you're now integrated, you can be more efficient because the transitions from hospital bed to community can be smoother. You can get all that waste out of the system. Well, the fact is that healthcare in this country has integrated to some degree, but it's not integrated more than what you would find on an organizational chart. So now Johns Hopkins Hospital, as an example, has an integrated delivery system on an organizational chart. We have hospitals, we have a health system that's over it, we have uniform administrative infrastructure in certain instances, but from the patient's perspective, the patient shows up in one of our docs' offices, and then the following week ends up in our hospital emergency room. The two don't talk to each other. Why don't they talk to each other? Because there's no electronic medical record. Now at Hopkins there happens to be a rather significant EMR. But in the current state of healthcare in this country, it's unlikely that those two providers will talk to each other real time. And that's true even if they're in the same system. So that's a problem. We've got to create that type of system. And we've got to not be incented to drive everything to the center of that system. What do you think the center of our current integrated delivery system is? It's the hospital. And why is it the hospital? Because the hospital makes all the money. The hospital is the big gorilla. Because you go to a doc might make a couple $100 per visit. You go into a hospital, you're getting $1,000 a day. You're getting $1,500 a day, depending on how much service you provide. You're doing a surgery, you can get $8,000 for the surgery. So the system is incented to drive everything to that big machine that's going to then create all this money, this revenue. That's what I call downstream. That has to change too, because we need to reduce the high cost, the high expense in our healthcare system by providing less of those high cost services, pushing people back into the community, pushing them back into primary care, community-based care, and bringing care to their home, new models of care, and that forcing them into these institutions, if you will, in these hospitals. Hospitals in the future, hospitals should really only be an ICU. You guys know what an ICU is? Except when you, women will appreciate this, you probably do want to go to a hospital to deliver a baby. But otherwise, and you probably do want to go to a hospital for major surgery, obviously, and then be there for a few days, but hospitals should really be only for those purposes. And that's not the current state of affairs today. You can go to a hospital basically for everything and anything, depending upon the insurance plan that you have and whether or not they're going to let you do it or not. So this needs to all change. So what's the framework? What's the new framework? And I like to talk about population health as the framework, and you all may not know that term, but it's a bridge between public health and delivery of health. Right now we have two systems. We have a public health system, we have a healthcare system, and they don't necessarily talk to one another. So you just think about the city of Baltimore, and we know what the public health concerns are in the city, and there's a lot of them. But we don't have a healthcare system that's built to address them. They don't even know. The healthcare system may not really know what the community needs are. They're building a healthcare system to provide cardiac surgery and provide OBGYN and to do all these things that hospitals do. So the new healthcare system needs to connect the two. It would not be something. Wouldn't that be something if the hospital is incented to only provide the healthcare necessary to meet its community's needs? That's the new world. So that completely switches things around. Hospitals no longer in the center. And then the delivery system is thinking differently. They're not thinking about just how much money can they get. They're thinking about what's the right thing for the patient. So the new terms that we're using, right care, right time, right place, right price. Everybody's talking about it. Have you guys heard it? That's the healthcare, that's the new world. We want the healthcare system to ensure that the right care is provided at the right time, at the right place, and at the right price. Completely different from the current system that we have. Patient-centered, we want it truly integrated so that all of these, you see primary care, hospital care specialists, all of these component parts of the healthcare system talk to each other, know where the patient is at any time. So at Hopkins, this is how we look at it. So this is a population health pyramid, we call it, population health pyramid. And for all practical purposes, this can be any population. So let's use my Johns Hopkins employees as an example, our employees and our employees' families. I have responsibility for providing healthcare benefits to that group of people, and I have their claims data, right? So I know what services they're accessing. By virtue of that, I can basically stratify my risk, if you will, because I can take my data and then we can put into this pyramid each member, each employee and each family member. And because I have the data, I know I can figure out how many of our employees and their families are in this level 1, i.e. high severity, multiple chronic conditions, sick people. I can figure that out. And Blue Cross Blue Shield can figure that out for their health plan. And the government can figure out for its population because it has the data. I know how many people fall into level 2 that are moderately sick or have lifestyles that could create in the future illnesses, moderate severity. And then I know who falls into level 3. So if I have a healthcare system that's addressing the population health's needs, then I could build a healthcare system to meet those needs in a very direct way. So what would I do? Well, in level 1, I'd build chronic condition case management. I'd educate people that are diabetic. I'd help them manage their diabetes. I'd make sure that they know that they don't have to go to the hospital for certain things, because I'm going to give you access to your specialist, and you can go there first. So I can design these programs to meet the needs of that patient population. Similarly with the moderately severe, I can design programs, I can educate, I can engage them in their health to keep them from moving up the pyramid. I don't want them moving up the pyramid because that's going to cost more money. We need to keep them healthy. And then finally on level 3, you all fit in that level, you're healthy. Well, over the course of time, we, the system, want to keep you there. We want you to stay down there. We want to help you stay down there. We want to give you a healthcare insurance plan that incents you to stay down there. This is a whole new different framework. Johns Hopkins Hospital doesn't think about its healthy constituency. It's only worrying about the sick. But Johns Hopkins Hospital also has primary care, specialty care, home care, managed care. They have populations they're responsible for. So if you think about their responsibilities in a different way, then you would build a different system. And that's our theory. Have we done this? We have, in piecemeal. So for example, in this top pyramid, there's a lot of very ill old people. Not surprising, right? Over 65, you tend to slow down a little bit. And if you've had chronic disease, then you tend to start seeing the ramifications of that disease as you get older. So we've introduced programs to say to these people, we're here for you as a system. And we're going to try to keep you healthy. We're going to optimize your health. How are we going to do it? We're going to give you a case manager. We're going to give you a health coach, somebody that you can call on. And it's not just somebody that's going to deal with your health care, but can also deal with your health insurance bills, your questions. Again, a navigator, a coach. ESRD, a little bit different. These are folks that have kidney disease and require dialysis, very serious disease. They have to go to dialysis centers a couple times a week. One thing we know is that to keep them as healthy as possible, they need to ensure that their puncture points where they put their dialysis, that it doesn't get infected. Because if it gets infected, they'll be in the hospital. How do we address that? We go visit them in the dialysis center. We say, how are you doing? We check it out. We check out and make sure that they're not creating any infection opportunity, and we teach them. Healthy at Hopkins is our wellness program for our employees. We've engaged our employees in this. Said, employees, we care about you, and we want you to care about yourself as well as you care for your patients. That was a major thing. Do you know that nurses in our organization, and this is an odd stat, 20% more likely to be obese than any other employee category in our system. We're not taking care of ourselves. We're taking care of our patients, great, because we're not thinking about it. But we need to think about it. And in 10 years, you could actually change the culture of a state, of a delivery system, of a population. Think about the success of smoking. 20 years ago, people were smoking. And now, despite the fact that I did see a few out there in the quad there, I was a little surprised. But smoking is thought very differently now, right? It's just not really something that you would expect of a population to be doing. It's an exception. That happened over 20 years. So it can be done. You can change culture. So is care management, this idea of putting nurses and people into partnership roles with patients, the panacea? Maybe. It's certainly valuable, but it's costly. And guess what? The federal government doesn't pay for this now. So the only people that can afford to do this are insurers that are at risk, that are at risk for the total cost. And so they're incented to do it. But the provider system, they're not getting paid for this. So the delivery system today is not incented to do this. They're getting paid fee for service, right? They're only getting paid when they see sick people. We got to change that. You've got to incent a primary care doc to actually take care of a patient and keep them well. So again, population health success, it's proven that it can work, but we have to move forward. We got to move forward big time in this. The healthcare reform legislation does very little in this regard, except that it does create an innovation center that would provide demonstration money to allow systems to begin this work. 5 required changes. Big areas, and I'm going to go through this quickly. We have to change the concept of a hospital. I've already talked to you about it. A hospital can no longer be just an alternative. It needs to be limited to certain types of things. And this downstream effect that I talked to you about, where all these systems are kind of incented to take everything down to the hospital, that needs to change. How is that going to change? You've got to change your organizational structure. You've got to take this hospital out of the center you've got to put community-based healthcare into the center, along with the patient. You've got to change the reimbursement model. This fee-for-service thing has to change. This is the billion-dollar question that I cannot answer, nor can any actuary or economist that I've brought to the table. I don't know how to do this. The federal government does not know how to do this. It is the federal government that's going to have to figure this out, because it is the Medicare program that basically drives everything that happens in the private insurance world. So changing the reimbursement model from this volume incentive to a value incentive has to happen. And then we've got to train docs differently. I told you about the old guys that I talked to about this. They have no idea what I'm talking about, because they're not trained to think about populations. They're trained to think about sick people who present to them at any particular moment in time. So that has to change. And then, yes, we do have to rethink end of life. We really do. I don't know what the percentages are off the top of my head. I knew at one point. But a huge amount of our healthcare dollars spent in the last 6 months of life. And we all know the stories. We're going to keep mom in the hospital for a couple more weeks because maybe, there'll be a miracle. And yeah, she's 95 years old, but we still hope for that. And who makes those decisions? Basically doctors. So again, this shows you the Johns Hopkins buildings, and this is the current organizational structure, if you will. All the hospitals are in the center, and then around are our physicians, School of Medicine, home care, my organization, community care, and the community. We need to flip that around. We got to put the hospitals on the outside. That's going to require a lot of guts by the CEO of these hospitals, because it's the hospital that's making the money. And they're going to be putting at risk their whole organization if they're by doing this. We got to change the reimbursement model. We got to move from fee-for-service to pay-for-performance. How are we going to do that? I don't know, as I talked about, but there are models that are being that are referenced in the healthcare reform legislation: bundled payments, partial capitation, paying for shared savings. If you take money out of the system, we'll give you back some of that. These are models that are being tested. They have to happen. Not going to happen by definition in this healthcare reform legislation. Will be studied as part of the reform legislation. Changing medical training. Focusing on management of disease, not just episodes of illness, end of life. Advanced directives, listening. I remember when my father was passing away, he always told me that he did not want the tubes. He had made it very clear, but at that last moment, the physician, the nurse, asked him, and he had his advanced directive. And he was asked, do you want, if you were to go into cardiac arrest, do you want me to resuscitate you? And he said, oh, yeah. And I said, oh, Dad, no, you don't. You've never wanted that. You've never, ever wanted it. And we've talked a lot about it. But at that last moment, right? And he goes, And of course, I didn't want to force him. But if that nurse had asked him again, or had just pushed him in any way, then he might have done something different. So the providers have to listen, and then they have to recognize they really do hold the power. So generally speaking, someone will listen to their doctor. And so they have to rethink how they provide end of life, particularly in our environments, because we love to take care of people. We love to give them every last test, because we're a teaching environment, right? We want to give them 16 times more than any other hospital might. We can't do that. We can't afford to do that. And it's not good for the patient. So why must all this happen? Why must we do this? Yes, we have to reduce costs. Yes, our citizens should get the highest quality of healthcare in the country. In the world. We owe that to ourselves, don't we? We should be aspiring to that. Well, I'll tell you why we have to do it, because you guys are going to demand it. At some point, when you all access healthcare, you're going to demand the same full service that you get from your phone, that you get from your cable company, that you get from your little apps, right? You find something, you get it right then and there. You're going to demand it. And you're going to walk in one day and you're going to have on your little badge or whatever you're going to wear, you're going to have your little flash drive. And what's going to be on that flash drive? It's going to be all your your medical information. You're going to be like, I'm not taking the chance of going into an emergency room and my docs not know that I have this history or I've been, under this type of care. That's ridiculous, right? You're going to demand it. And I can tell you, I got a BlackBerry. You all know what a BlackBerry is? I don't know, 2 years ago. It changed my life. I had to completely change the way I did my job. I didn't know that that would be the result, but I had to change overnight because suddenly I was getting all this information. It's like, oh my God. I had to think differently about how I did my work. That's going to happen quickly. Electronic medical records, billions of dollars in the federal budget to get the healthcare system connected, get them digitized. So right now you can go to your doctor and it's likely that your doctor's not on an electronic medical record. They may have a PC in front of them. They may be writing on it, but it's not doing anything. It's like Word Perfect or Microsoft Word. That's going to change. And once that changes and information starts flowing, physicians are going to have to act differently. And that all has to happen to get real reform. So, will we succeed? I don't know. We have to be able to be willing to appropriately size ourselves, i.e. maybe close hospitals because we won't need them anymore because they're only going to be necessary for really sick people, which means you're going to be closing your cash cow. That's going to take some guts. You got to be willing to compromise, and you got to recognize the service and outcome is going to be your differentiator because the consumer is going to demand it. It's no longer good enough to just say, I'm Johns Hopkins, which is, by the way, what we say. And it is Johns, not John. Johns. Got it? It's no longer good enough. You're going to have to prove it. You're going to have to prove your value. And it has to happen. It really does. We're not going to solve this healthcare cost crisis without it. Call me, email me with any questions. And I know I took too much time, so I'm sorry.
Hello. I just had a quick question regarding the socioeconomic state that seems to be tied in with the healthcare reform. That was the only thing that I was surprised you didn't touch on was like socioeconomics. It seems like the healthcare right now is geared toward middle America. And so how does the healthcare reform seek to reach out to the minorities and the big economic gap that's happening in America right now?
I should have highlighted it, but the hope is that once we switch to a population health model, that we will recognize that that population includes all populations, including minorities, and the health disparities issues then could be addressed, and whatever we're going to cover everybody, right? That's the hope. And once you cover everybody, then all of those populations and their respective needs are going to have to be taken into account, and then systems built to address them. That is arguably the intent here. Obama wants universal health coverage so that he can begin to address healthcare disparities, inner cities and the issues there, and then the connection of public health to those populations' needs. It's a major driver behind a lot of this. Most of the uninsured are poor. The other thing I'll say is that it's been pointed out to me in this presentation that I don't reference and I should is tort reform. That tort reform is also a critical component. Medical malpractice reform is also a critical component of any healthcare reform success story.
Hi, I'm actually from Baltimore, so a lot of what you said resonated with me. I went to Friends School of Baltimore.
Oh, did you?
Actually.
Great.
Yeah, right down the road. But my dad actually
I probably
works.
know your mom and dad then.
Huh?
I maybe know your mom and dad then.
My mom
We'll
works
talk later.
Okay, sure. But my dad
Baltimore's a
works.
small town.
Yeah, it is. But my dad works in healthcare, networking databases and stuff, and also works with trying to minimize costs to the government with healthcare costs. And I was just wondering, you kind of touched on it a little bit, but will the government be able to support the public option as well as continue to support Medicare and Medicaid and Social Security and all of those programs that require just so much money? It's astronomical.
Yeah. Only if what I suggest needs to happen happens. Because right now, under the current healthcare reform legislation, and I know the CBO is projecting savings to offset the initial costs, but it's pie in the sky. You cannot offset the increase in healthcare costs that are going to be provided to now 30 million people without reducing costs in the healthcare system pursuant to the strategies that I laid out. So without all of that, the government programs are just going to get bigger. And what does that mean? Then we're going to have higher taxes. I mean, it's pretty simple. But there are ways to address it if people are committed to it.
Hi. You spoke about how we need to change from the churning aspect more towards a pay-for-performance aspect. But how do you solve that if we're going to move the emphasis more towards community health organizations? A lot of that's going to fall upon people who choose to go into general practice of medicine. But as of right now, there's nothing that incentivizes a doctor or a student in medical school to move towards general practice. The money is in specialty. And the churning process doesn't incentivize a person to move into that because the lifestyle is miserable.
Right.
So I guess how would you change?
So I stated at one point that the federal government controls a lot of this. The Medicare fee schedule, fee-for-service schedule, which is decided on by a lot of different infrastructure, a lot of different people, makes the decision as to what to value a primary care visit for purposes of reimbursement as compared to a neurosurgery procedure. If tomorrow Medicare said, rather than pay $100 for that primary care visit, I'm going to pay $300, then you will see an increase in interest in primary care. Because they will then know that they have the opportunity for a higher salary. So the pay-for-performance system is going to have to fix that too. Because what the specialists are arguably upset about now is that the only ones that are being talked about with regard to new money is primary care. And the specialists are saying, well, why is, I'm a neurosurgeon. He's just a primary care doc. I think I need to be paid 3 times, 4 times as much. I'm the rocket scientist, right? So it really has to be addressed both with regard to the payment models, but then also the decisions as to where you value your resources. And primary care will not recover from the loss of interest without payment reform, without changing the value, and then without giving the primary care physician more authority and autonomy. One of the students works for Patient First. I was talking to him earlier. And what's happening now is that primary care docs they're not even taking care of sick people anymore. Because they have to schedule their day because they need the money, right? They need to get paid. And so they're scheduling well visits. They're not even seeing sick people anymore. And that's boring. I mean, primary care docs are bored out of their minds because they're really just doing physicals, right? They don't want to do that. So if the system can be changed where you put more money into primary care and then you provide an incentive for primary care docs to actually be able to take care of patients across the spectrum and make it just much more of kind of what was envisioned with Marcus Welby. You probably all don't know him. It's a TV show. And so it's going to take a lot of transition.
If this bill passes, you were talking about the need to have more money, obviously, for the cost bubble and more physicians to be staffed for the extra 30 million people. But if the bill passes, what is the administration looking to do in terms of incentivizing more physicians in general? I mean, how are they just going to increase the amount of physicians?
Yeah, it's a good question because there's nothing they can do in the short term. It takes a long time to train physicians. So they are building into the reform legislation money to fund more medical students and create more what they call medical slots. And then they are also incentivizing the development of or the growth of ancillary professions, NPs, PAs, techs, case managers, to incent more of those types of less costly providers which can then hopefully meet this gap. But it's not a clear road to success because there's 30 million people and there's a healthcare system that's already stretched. And so there's no clear map to that, but there are some tools in there.
Just going off of what she just said, is there like a fear that medical schools will become less selective and that could affect the quality of healthcare, allowing more students in?
Yeah, that's an interesting question. I don't think so. I think there's still enough competition in the med schools, amongst the med schools, that I think that they would always be ensuring that they have high quality students applying. It's a long haul, med school. It's 4 years plus internship plus 2 or 3 years of residency, depending upon, and it's not easy. So even if they were to be less selective, those students wouldn't make it. I don't think that's a concern. Cynthia, there's one question here.
I guess in regards to mid-level practitioners, I know much of my family works for the Penn healthcare system, and they're only utilizing nurse practitioners currently. They refuse to hire physician's assistants, and they use nurse practitioners in the capacity of health educators as opposed to in clinical practice. Do you think we'll see a trend more towards clinical autonomy in, I guess, mid-level practitioners with reform?
Absolutely. Yeah, and it's an interesting transition. I have one of my medical directors is 72, and he insists that he has no interest in retiring, much to some of our chagrin, and he is refusing to recognize what you just said because he's from the old school, and he thinks that the physician is the power. And I have a lot of nurses that are at same level positions as he is, at least with regard to power, if you will. And they constantly are fighting him on this to say you have to respect the nurse and the mid-level provider and what their value is. And I think it's going to reverse. I think if you think about population health and you think about taking care of a patient across the continuum, across their lifetime, then that care is going to be provided by someone other than a doctor. That happened in the world of dentistry. You all may remember. You probably only know the new world. But I remember when there was a shift when you went to the dentist, you used to see your dentist. Well, now you see your dental hygienist. Your dentist walks in and he smiles and and he's there for 30 seconds, right? Because your hygienist is who you see. They take care of you. And you feel fine about it. That's what's going to happen in healthcare, too. It's already happening on the primary care level. Thank you.